Excellent. Well, welcome everyone. Thank you for joining us today. My name is Lee Frame, and I am the director of the Resiliency and Wellbeing Center, as well as a few other things like Chief Wellness Officer. And I'm very excited to have with us our former director and the former Chief Wellness Officer, Dr. Lorenzo Norris, also a good friend of ours. Always good to have you back. Dr. Norris currently serves as the interim senior associate dean for MD programs for the George Washington University School of Medicine and Health Sciences. In this role, Dr. Norris has broad leadership over the mission and outcomes of the UME, GME, and International Medicine MD programs. Dr. Norris served as the GW Academic Medical Enterprise Chief Wellness Officer from 2021 to 2024 and co-founded the GW Resiliency and Wellbeing Center. Dr. Norris is an associate professor of psychiatry in the GW Department of Psychiatry and Behavioral Sciences. He's also board certified in psychiatry with a focus on clinician well-being. He received his MD from Case Western Reserve Medical School, and he completed his residency at Mount Sinai Hospital in New York City and his fellowship at Yale New Haven Hospital. Dr. Norris regularly publishes papers in academic journals and national magazines and has presented at major educational symposiums and national meetings. He's guest edited 4 issues of Psychiatric Annals with themes ranging from cancer and depression to hope and cancer survivorship. Currently, Dr. Norris serves as editor-in-chief of MedEdge Psychiatry, the leading peer-reviewed source of practical evidence-based information and the leading independent news source for the practicing psychiatrist. Dr. Norris currently serves as the American Psychiatric Association Committee of Continuing Medical Education and Lifelong Learning, or CMEL, and is the chair of the APA Committee on Burnout and Wellbeing. He has previously served as a member of the APA Council on Psychosomatic Medicine and is the former 2-term DC chapter president of the Washington Psychiatric Society, as well as serving on the Katzen Cancer Research Center Board of Directors. Dr. Norris was the recipient of the Leonard Toe 2011 Humanism in Medicine Award and has been recognized as a Washington top doctor for multiple years. He's also a top doctor in our, and we're very glad to have him. So with that, welcome.
All right. Thank you so very much, Dr. Frame, Lee, and it's really good to see some familiar faces. I haven't had a chance to really work with my colleagues in the Resiliency and Wellbeing Center as closely as I have in the past, but really the Resiliency and Wellbeing Center continues to do some really amazing things. And I'm just so proud of the accomplishments that they are achieving under Dr. Frame's leadership. So with that being said, I'm just going to jump right into it in regards to the topic today, and it's going to be ADHD in women. I'm going to have a particular focus on, if you will, adults as opposed to children. I'm going to have a particular focus on different ways in which we can start to think about the diagnosis of ADHD and maybe challenge the audience to start to think about beyond just the syndrome of ADHD and how we actually start to think about cognition and attention as a whole in females. And that way we will not miss the diagnosis. So I want to highlight some evidence. I will have a brief case presentation to start, and I would pepper this with some of my own experiences in the with the patients that have been honored to share their lives and treatment journey with me who have been formally diagnosed with ADHD, as well as who've had other issues in regards to attention and cognition, regardless of their psychiatric diagnosis. So with that being said, let's just go ahead and get right into it. I don't have any disclosures, even though I should have put that as a slide. Our learning objectives today describe the typical manifestation of ADHD presentation in females, identify the current best evidence-based pharmacological and non-pharmacological treatment options for females with ADHD, and summarize, let me just move this, summarize 4 major psychological themes females with ADHD may encounter at various points in their life. And when I'm referring to females, I am, for the purposes of this lecture, referring to those who have been at birth, they were biologically given the definition of a female of a woman. So that is my what I'm using as in regards to this definition. So, all right, with that being said, oops, let me just go back to my slides here. Okay, there we go. All right. So let's start with a case presentation or case vignette. Okay. And this is not untypical with what we would encounter here. Um, the patient is a 22-year-old female professional student who was previously diagnosed with generalized anxiety disorder, who now presents with increased anxiety, despite being on a therapeutic dose of escitalopram, Lexapro. The patient has seen limited improvement in her symptoms over the past 6 months. It is now having a significantly below average performance in her coursework. The patient has been a high performing student in high school and college and hasn't noted any change in her study approach, stating, "It must just be my baseline anxiety or imposter syndrome that is getting in the way." The clinician does typical exam in regards to review of systems, family history, things of that nature. For the sake of time, I'm not going to put out the entire full exam, but I'm just going to give you what the presenting, if you will, symptoms were. Primary presenting symptoms: difficulty sustaining attention in tasks and activities, tendency to become easily distracted by external stimuli, procrastination and difficulty completing tasks on time, disorganization and difficulty managing tasks and responsibilities, anxiety concerning academic performance that does not extend to other areas. And here are some of the coping strategies that we utilize: relying heavily on reminders and alarms to keep track of activities, creating extensive to-do lists to manage daily tasks and maintain organization, utilizing highlighters and color coding systems to prioritize tasks and stay focused, engaging in physical exercise or mindfulness practices to manage anxiety and stress. So, when you hear this, again, obviously you'd want a bit more information, but here's some things to think about when you hear this. Okay. What might be unusual regarding the presentation of this patient with a primary diagnosis of generalized anxiety disorder? What type of comorbidities might be present in a patient with this symptom profile? Is this imposter syndrome? What additional information would you want for a comprehensive diagnostic assessment? Um, if anybody wants to put anything in the chat, they can. Or if you feel like you want to shout something out, by all means, go ahead. And I respond to Lorenzo just fine. If anybody wants to put something in the chat, also. Okay. Let me tell you a couple things in regards to when I see this presentation, which is not unusual. Um, the one thing that I frequently will see if I'm asked to, if you will, re-diagnose a patient, or if you will, work up, or if I'm seeing a patient who reports either treatment-resistant anxiety or depression, um, is when you look at their symptom profile and you compare it to DSM-5 criteria or things of that nature, they don't actually at times give you a symptom profile that is consistent with a primary anxiety spectrum disorder, whether it's generalized anxiety, social anxiety disorder, a specific phobia. They don't give you that specific profile. Yes, anxiety is associated with it, but it's not necessarily the salient or the biggest point. All right. Um, the next thing that we typically see in these type of situations, I find that clinicians or others, they're not always actually doing a full assessment and screening for all the potential comorbidities, including ADHD. They can commonly present with females or with people in general, but definitely females, particularly at transitions points. This is not, I've had this come up a couple of times. This is not imposter syndrome. All right. This is if you will, a patient who is having very real challenges in regards to maintaining and sustaining their attention in a very rigorous, if you will, coursework or academic environment. I could pick any professional course, whether it's a PhD degree, law, medicine, engineering, take your pick. I've actually seen, actually, I think all of those in terms of this, because this case is an amalgamation of other cases. Um, in regards to this diagnostic assessment, some of the things that you would be looking for as a clinician would, like, am I using scales? Do I have a full family history? Do I have collateral information? But where am I going at with this? The best way for you to not miss a diagnosis and to make sure that we are making sure we're giving all of our patients the best opportunity is to have issues with attention or challenges with attention or cognition as part of something that you always assess, moving beyond just ADHD. But how do I think about attention and cognition in every single one of my patients? Because attention and cognitive issues can cross all the boundaries. So whether a patient presents with anxiety or depression, am I asking myself and going through this with my patient, like, am I actually thinking about this? So that kind of will start the frame for the rest of this presentation, that I encourage us all to not just be narrow focused in terms of one particular syndromal presentation or typical or biased presentation of ADHD, and start to think about how we best support and strengthen our patients, our clients, in regards to if they report with symptoms, cognitive or attentional symptoms. Now, now let's talk a little bit about ADHD, just some basics here. All right. Um, First off, it's quite prevalent. It's a neurodevelopmental condition. I can't emphasize that enough. It's a neurodevelopmental condition that is thought, nobody knows the exact reason or pathogenesis why, but there is felt that it occurs early in development. Some of it can have etiologies in regards to synaptogenesis, in regards to how our neurons are formed and connect, as well as neurotransmitter abnormalities in just circuitry. But it's neurodevelopmental. And basically, what I mean by that is that it can have a very early on start. All right. Typically, this ADHD can be first diagnosed, at least in boys, at the age of 7. We're going to find out that in girls that there is a lot of underdiagnosings when they are younger. All right. So, but the prevalence globally is 2.6%. And then when you get to ages 18 to 44, it's 4.4% among 18 to 44, between 18 and 44. And ADHD affects 5 to 10% of school-aged children and does persist into adulthood, roughly at about a 50% ratio. Okay, comorbidity is absolutely present, and you could also argue that comorbidity is the rule in psychiatry, anywhere from mood disorders occurring in 2.7 to 7.5% of cases of adult ADHD, and anxiety disorders in 1.5 to 5.5%, as well as substance use disorders at a rate of 3%. Okay. Now, in regards to the diagnosis of ADHD in females, it was historically considered essentially, not literally, but essentially a male-only disorder, which has led to the underdiagnosis of ADHD in females. The childhood ratio of boys to girls in ADHD diagnosis is approximately 3 to 1. So 3 boys for every girl, while in adulthood it is closer to 1 to 1. When you look at the research, this leads people to believe that, and rightfully so, that there is underdiagnosis of ADHD, which is a neurodevelopmental disorder, early on. And one of the reasons that this can occur is because of the way in which clinicians are trained in terms of recognizing symptoms of ADHD in females. The second is that females tend to present with ADHD inattentive type, as opposed to ADHD hyperactive type. All right. And again, this also gets into the training of how our clinicians recognize ADHD, not only in children and adolescents, but also in adults in terms of what could be gender differences. So, but I would also add in regards to that, the appropriate use of different scales and valid techniques. I'm going to talk a bit about different things that you can do to take into account when diagnosing um, females with ADHD. However, I want to put that with a grain of salt. I think your best approach is to have as a clinician, is always to have a spirit of curiosity and collaboration with your patient. Because in my mind, once you've seen one patient with ADHD, you've seen one patient with ADHD. If you're not actually collaborating and really being really curious about what your patient is telling you and how those symptoms line up and how you can treat, you're going to miss it. So the idea is just to always have it be part of what you do as part of your evaluation in terms of thinking about cognition and attention, regardless of the presentation. That way, that's the best way in my mind for you not to miss this. Okay. And again, also I mentioned here, persistence from childhood ADHD. Studies have report that approximately 40% of patients go on to have significant ADHD symptoms. So, pathogenesis. The exact pathogenesis isn't known, but again, we really think that it has a lot to do with prefrontal cortex dysfunction, which I'll talk about a little bit later. And the two neurotransmitters most notably associated with this are dopamine and norepinephrine, which are obviously two of the neurotransmitters or systems that we utilize to treat many of our psychiatric conditions, or two of the neurotransmitter systems that we heavily modulate when the treatment of our of psychiatric conditions, notably major depressive disorder, all right, as well as anxiety disorders. But dopamine and norepinephrine, one way to think about this is that these neurotransmitters in the prefrontal cortex help modulate the noise to signal. noise to signal, how much in terms of that cognitive processing, how much do you filter out things that are unnecessary, X, Y, or Z, versus being able to signal the signal and focus on what is pertinent or germane. All right. And then core symptoms. There's basically three core symptoms in ADHD: inattention, hyperactivity, and impulsivity. Again, as I mentioned before, females tend to present with the ADHD inattentive type. There are various theories of this, but one theory in regards to that is actually has to deal with societal norms in that females learn different, if you will, coping strategies and things of that nature to conform more tightly with social expectations. In other words, there will be less of a hyperactive, impulsive presentation. I think that I'm I've seen those theories and I understand that. However, I still would say I'll be very curious if when you do a very thorough evaluation and dig, if you won't see some of those same hyperactive symptoms. But I do think it's fair to say that the inattentive symptoms have in research been the more predominant symptoms that at least initially manifest on, if you will, a diagnostic interview. So that is something just a take home point to think about, that when you're screening for ADHD in women, you really want to think about the inattentive type of ADHD. Okay. This is the DSM-5 criteria for ADHD. It's broken down into two parts: inattention, and then the if you will, the hyperactivity and impulsivity. I put this down here for reference, not for us to go over it. I just put it down here so that you actually know how this is commonly diagnosed. Again, with the inattention, you need 6 or more of the following symptoms that have persisted for at least 6 months. All right, the symptoms are listed here. Again, and I've actually shortened this a bit. They give examples in the DSM-5 for each of these. However, if you were to just go by the symptoms alone, just off of this, I think not only would you miss it in females, you miss it in males also. I think you have to uh, really have to understand the patient's life, their journey, in terms of the different ways in which these symptoms can manifest. So you can have 6 or more of these symptoms in inattention, and also you can also have 6 or more symptoms in the realm of hyperactivity. All right. Now, based off of the criteria, you can have inattention and or hyperactivity. Either one will do it. All right. Typically, when we go through and we talk about, if you will, the in terms of ADHD, regardless of sex, the hyperactive symptoms tend to decrease, whereas the inattentive symptoms start to increase over time. And I have a slide illustrating that. Again, all of this is for just reference to see how clinicians typically make this diagnosis. All right. Now, one caveat that came about also that didn't work in people's favors, particularly with adult ADHD, was there used to be a very firm requirement that the ADHD symptoms had to manifest at the age of 7 or before. Um, while the rationale behind that, with it being a neurodevelopmental disorder, you can kind of follow that. The issue is that a lot of people go undiagnosed, and also it becomes rather difficult in regards to trying to, in terms of recall bias and figuring out what was going on. If someone presents to you as an adult with these symptoms, and then you cannot make a diagnosis unless they had a diagnosis of at the age of 7. Well, that becomes rather difficult. As well as we can leave a number of people that could benefit from various forms of treatment, as well as an accurate diagnosis, undiagnosed and untreated, because we have this, if you will, somewhat artificial stop point of 7. So I bring that up in regards to just challenges. Now, let's just take a look at some of the brain areas affected. Okay. Or first, I'll start with how you think about ADHD. And this is kind of how I think about it. And this is taken from Stephen Stahl, Psychopharmacology, one of my favorite ones. You take ADHD, you break it down into the symptoms. So again, inattentive symptoms, hyperactive and impulsive symptoms. And then for each one of these symptoms, you can have an associated brain region. With the inattentive symptoms, we have selective attention, sustained attention problem solving, hyperactive, and we have, for the inattentive symptoms, we have selective attention and sustained attention problem solving broken down into those two components. All right. So with each one of these, we can link to a brain area. So sustained attention and problem solving is linking to the dorsolateral prefrontal cortex. Impulsive symptoms to the orbitofrontal cortex. Hyperactive symptoms to the prefrontal motor cortex. And then selective attention to the dorsal anterior cingulate cortex. All right. So what do all of these look like? So this, if you will, this is illustrating, if you will, problem solving and selective attention. We start in the dorsolateral prefrontal cortex. We go right here to the striatum, and then that goes to thalamus, and then we form a loop. All right. This is a proposed loop, corticostriatal thalamical cortical loop. And this one is tested by an in-back test. Basically, uh, a patient has to identify the number, the colored number. They can do a zero in back, or they can do, if you will, a variant in which they show you, like in this particular case, number one, and then they show you another screen, but you have to remember what the first number was. So these are just an example of different ways in which they attest or this they test for certain symptoms in ADHD. Next is the orbital frontal, or not orbital, the let's see here. Yeah, orbital frontal cortex. So we start there, all right, and then we go to the thalamus, and then we loop back. All right. So with that, you test that. Actually, I'm sorry, that's the dorsal anterior cingulate cortex right there. You can test this with the Stroop task. All right. Basically, in this, you give a patient a word. All right. And they have to say the color and not the word. So when I see this word here, blue, I'm supposed to say orange and not blue. So that's a Stroop task. All right. And that gets at the idea of selective attention. Um, Part of me feels like the past couple of months have been one, if you will, test of selective attention for all of us, but I digress. So that is the dorsal anterior cingulate cortex. All right. Then we have impulsivity. All right. Again, with this same loop. All right. And then we can do the same thing for hyperactivity. All right. Forming more loops. Okay. Again, this is simplified and hypothetical, but I felt as though it's important to think about this from a neurodevelopmental as well as when applicable, a brain, if you will, or a neuroconnectivity issue. All right. So again, when we think about ADHD, think about it in terms of tuning. All right. And how your prefrontal cortex in those areas take in information, cognitive information, and tune it. Again, reducing the noise and optimizing the signal. All right. So orbital frontal cortex, this is when you get your limbic and your motor symptoms of impulsivity and hyperactivity. Uh, the dorsolateral prefrontal cortex and the dorsal anterior cingulate cortex is cognitive, and that's where you get the issues in regards to problem solving, as well as sustained attention and selective attention. So again, when we're speaking about these areas or ADHD, we can break down these particular symptoms, the inattentive, into selective attention and problem solving, and we can link these to hypothetically malfunctioning brain areas. I've simplified this quite a bit, but it still is useful. All right. One of the reasons I bring this up is because sometimes people may think this is an issue of will or desire or something of that nature. No, we believe this is a neurodevelopmental disorder. We have neuro imaging evidence as well as genetics, as well as other studies, including CTs and functional MRIs, that show us that these areas are not functioning optimally. So I always bring that up because that's one of the first things sometimes I have to address with patients, because there can be at times a great deal of stigma associated with mental health, but also ADHD. Okay. Now, in addition to those brain regions I just showed you, there's the ventral medial prefrontal cortex. And the only reason I'm bringing this up, and I'm going to make this really quick, is that all of this exists in the prefrontal cortex, but this area is also associated with other things in terms of conduct disorder, bipolar disorder, and oppositional defiant disorder. Why do I talk about this? Because untreated ADHD from a neurodevelopmental standpoint can put you at risk for all other, if you will, mental disorders. All right. And they're all in the same region. So the point of this slide is to illustrate just that. You have this ADHD in conduct, which again is typically seen early on in 5. Then after that, you have anxiety disorders as well as schizophrenia. Then you follow that with schizophrenia, substance use, and mood disorders. What some authors and researchers argue is that if you do not treat or intervene early in neurodevelopmental disorders such as ADHD, you run the increased risk for anxiety disorders, as well as potentially for schizophrenia and these downstream effects in regards to other things, substance abuse and mood disorders. Too frequently, I actually see patients come with mood disorders and or substance abuse. And we have to by definition start there in terms of treatment. But then when we go all the way back, you get a history of either a neurodevelopmental disorder such as ADHD, that if we would have had the opportunity to intervene earlier, and I'm not just talking strictly pharmacological, we might have had a different course or trajectory, consequently missed opportunities. But right here also, particularly ADHD, I get very curious if that ratio of male to female diagnosis early on wasn't 3 to 1, how that would affect our anxiety disorder bump right here, particularly as a result with females. Um, Females are, in terms of the lifetime prevalence of any anxiety disorder, are literally twice as likely as males to have an anxiety disorder. Depending on the evidence base that you look at, it's anywhere from 27 to 30% of females will have a lifetime prevalence of one. If you pick any anxiety disorder, they'll have a prevalence of one of those, 25 to 30%. So I get very curious about that and the missed opportunities to come when we don't have an earlier diagnosis, or if we don't diagnose ADHD appropriately and our patients are getting at best partially treated. Okay. Now, I've talked to you about this idea of cognitive function and noise versus signal. I like this slide because it gets at the idea of arousal and, for me, stress. So when we're working with folks, we don't want too much arousal and we don't want too little arousal. If you have deficient arousal, you can get symptoms of inattention and cognitive dysfunction, as well as you can outright fall asleep. Um, and there you have it in regards to just this little cartoon or schematic in terms of, again, that's the prefrontal cortex region right there showing that dysfunction. Then you can actually get excessive arousal, which comes from cognitive dysfunction or overstimulation. In ADHD, you can be vulnerable to both. All right. Either not enough arousal, which can give you symptoms of inattention, or over arousal. All right. Which can also lead to dysfunction. All right. But it exists all along a continuum. So some of the coping strategies that people use, I'll say procrastination as an example. One particular advantage, or some people, if you talk to patients, the procrastination can actually build up that motivation or that energy to increase the arousal. But unfortunately, that type of tactic doesn't work when you start to enter into higher levels of demand or performance, whether it's in school or at your job, because it just won't, it'll actually end up backfiring and put you into cognitive overstimulation. But again, it's not too little arousal, it's not too much arousal. It's right that awake, alert, creative problem solving. In other words, we don't want to be in a fight or flight mode, nor do we want to be asleep. So I put this slide on here because it goes very nicely with, if those of you who've listened to the Resiliency and Wellbeing lectures before will recognize this one. One of my favorite ones, the stress curve. All right. You don't want to get too aroused or go into distress, heavy distress, nor do you want to just be so chill that you're not actually optimizing things. So you really want to live really in that middle zone, that green zone right there. Maybe occasionally getting into that, like pushing yourself to that adaptation zone. But again, literally in our brain is wired for us to really be at our optimal in this range. All right. Not too little eustress, not too little eustress, not too much distress. So that was the reason why I liked those other two slides with it. Now, um, gender differences in ADHD diagnosis. All right. I'd already mentioned this. Societal norms influence the perception of ADHD, with females often, per researchers, masking their symptoms to avoid social judgment for violating feminine norms. Females are more frequently diagnosed with ADHD attention type, exhibiting symptoms like distraction, disorganization. We talked about this. And males are diagnosed with ADHD at higher rates than females, with 70% of diagnosed children being boys, and girls are often diagnosed unless they exhibit significant externalizing symptoms. In other words, um, that fidgeting, that jumping up, getting out of your seat, that being disruptive in class, girls would have to exhibit a significant amount of that in order to be diagnosed. I do think that there's something to be said in regards to these societal norms, but again, as well as the masking of the symptoms to avoid social judgment. Again, though, I'm careful with that because in my experience with patients and everyone, the real money is in how you work with the family, the patients, and understand how any particular symptom is presenting in that patient. I probably think more to the physician training and the bias of this isn't early on, this is not a female condition, it's mostly a male condition. I think that has as much to do with it than any type of thing or coping strategy that a girl or a female could utilize. Because if you do a comprehensive interview, once you get into that, you're going to figure out what that strategy or that coping strategy is doing, and you will come to that diagnosis or that realization. So if I had to put something on it, I'd have to really think about that inherent bias, which we get into now. The gender bias, it definitely does exist in clinical and research settings. They've shown this. As a matter of fact, to give you an idea of what this looks like, in one study, they took a clinical vignette, all right, similar to what I gave you, and it was the same vignette, except they changed the sex of the person in the vignette. Males were diagnosed again at that ratio anywhere from 3 to 4 to 1 compared to females. It was literally the exact same symptoms, literally the exact same. All they did was change the sex. So studies like that, and when you look at it, I get really concerned about that inherent bias that clinicians can have in regards to the presentation. Because I was always taught you can be looking at something directly and see it exactly, but if it's not in your mind's eye, if you're not thinking about it, it doesn't matter. You will miss it. Okay. Now, in regards to just general principles, when we're thinking about diagnosing ADHD, assessment of ADHD in adults, you should always use a combination of a structured or semi-structured interview with specific diagnostic questions. Many of them exist, but I think it is important because otherwise you're going to do a limited interview. All right. You can also supplement this with rating scales. I've listed a couple that are there that are evidence-based, but please do keep in mind that the rating scales in and of themselves are going to likely give you too many false positives as well as false negatives. The rating scales are meant to supplement, if you will, your full-on evaluation of the patient. All right. Neuropsychological testing can absolutely be used to complement the interview and add further specificity to the diagnosis. But really, that I view that as I utilize that in more complex cases. If I really want to get a really, really, really sharp idea of where the cognition is at. All right. And collateral information can be potentially can be helpful. People might be wondering why I add the caveat. I add the caveat in part because it really depends on who's giving the collateral information. You can't always assume that you're going to get the best collateral information from family or schools unless they know what they're looking for. Now, I think if you're working with people over time and you've built a relationship, I feel so the collateral information can be absolutely invaluable. But these are just general principles that you need to think about. All right. Okay, so for key points for detection of ADHD in females, as I already mentioned before, inattentive and hyperactive symptoms. I think if you are not paying attention to the inattentive symptoms, you are going to miss it. I think if a patient presents with major depressive disorder, generalized anxiety disorder, and they talk to you about problems at work or maintaining or sustaining work or their attention, and you immediately view that as an issue primarily with motivation or a lack of optimal treatment of depression, I think you're missing an opportunity to really ask that person, where's their attention at? All right, in terms of their attention, how are they with the problem solving? And also, where is the extent of the challenges that they're facing? So I think that again, but if you're not thinking about this, you're going to miss the inattentive presentation. All right. Studies have shown that inattention in females with ADHD may present as being easily distracted, disorganized, overwhelmed, and lacking effort or motivation. I just spoke about this, all right, but I want to maybe dive down a little bit on this. Because when I talk with folks, particularly this because this was in the literature of perceived as lacking effort. It's actually not effort or lacking effort. It's actually they are extending so much effort or it's taking so much to get this done in terms of the cognitive load. But it's not a lack of effort. It's a lack of, if you will, cognitive reserve to an extent that can limit things. So again, I think it's really important to start to think about that in regards to this. But when I start to see these symptoms, particularly in someone that I start to treat with anxiety or depression, you absolutely want to again ask yourself, is there something, a comorbid condition that I'm missing? And ADHD or symptoms of attention can be one of those. Um, this one. The symptoms may become more obvious later in females, often during periods of social or educational transition. I can say the same thing for males, but I definitely, in my own clinical experience, I see this quite frequently. I've actually had the opportunity to work with a female. It might be unusual for some, but literally from college all the way through professional school and up to early years in in professional settings. And I've seen how the ADHD symptoms wax and wane. All right, in terms of different periods, along with the symptoms of anxiety as well as depression. So I personally have seen that, but those transition points, an excellent opportunity to screen, all right, for symptoms of inattention and cognitions. All right, symptoms may absolutely be exacerbated by hormonal changes during the menstrual cycle, pregnancy, and menopause. Absolutely. I frequently can certainly see that. Particularly if there's also comorbid premenstrual dysphoric disorder. I've absolutely seen that. I personally have not seen the menopause, but I've absolutely seen the, if you will, the strain in ADHD symptoms with menstrual cycle as well as with pregnancy. Okay. Difficulties with emotional lability and emotional dysregulation can also be present. This young in younger girls, they can be vulnerable to bullying, including physical and social relational bullying. Females with ADHD tend to become sexually active earlier than their peers, and rates of contraction of STDs and infections can actually be elevated. And, and again, compensatory behaviors may mask behavior impairments and delay referral for treatment. So these are just some of the evidence-based things that people have looked at, and they have seen that in regards to associated features and vulnerability of ADHD in women. Again, I can't emphasize enough that I think this is a starting point for a discussion. I think if you just focus on any one particular of these things, you will miss it. But if you have them in your repertoire and you're constantly thinking about them, then it will inform, again, collaborative discussion with your patient as well as a proper diagnosis. So, this I like this, if you will, schematic. This was taken from Young and colleagues, but I really do like it because it starts to talk about what are the different things that you could see at different points in the age range, and it's broken down into different sections. So again, education and vocational, you can see all of these things. All right, but notice how it changes. All right, from the age range. Okay. Now, I also pay, but notice we're in that low self-esteem in relation to academics tasks start and educational exclusion, all of these type of things. So you can use something like this to go back in time and just start to pepper or ask these questions, which a lot of people don't necessarily do. All right. Next, you can also see, if you will, again, in different domains, social as well as different addictive behaviors, again, on a timeline. Notice that involvement in bullying, victimization, and cyberbullying. Difficulty maintaining peer relationships. Absolutely. Absolutely. I think you could look for this in men, but I absolutely do feel as though that is something that I certainly do look at in women in regards to the age range in terms of where the peer relationships and the networks are at. And then you can look at the addictive behaviors. But again, you'll start to see all of these things along this timeline in regards to the presentation. Okay. And this starts to get at the different comorbidities that you can also see in regards to ADHD. So this is just a different way to think about it or to look about it when you're thinking about ADHD and what kind of different things or different comorbidities might be there. All right. So this slide gets at this neurodevelopmental aspect that I was talking about. Notice that the inattention, it may be sub-threshold initially, but as you get to school age and further, it starts to become prevalent. Whereas the impulsivity, again, it'll stay there, but it will start to go down as you hit adolescence, college, and adulthood. Hyperactivity starts to take a big drop, all right, particularly into adulthood. And then you start to also recognize the comorbidities. So, but if we are typically catching or diagnosing women here when there's prominent inattention, and I'm going to say here, we've really missed a lot of opportunity here to intervene. All right. Particularly at this point. terms of a number of different behavioral, academic, and self-esteem issues. All right. We've missed opportunity here. All right. So we have to have a really high index of suspicion, and curiosity, not to overdiagnose, but again, to think about what are challenges with attention and cognition, regardless of the diagnosis. All right. So tips for enhancing the ADHD assessment. Again, um, I talked about the use of rating scales, but ones that have provided female norms. Why do I talk about the rating scales? That may help with the reduction of bias. It's also standardization of your, if you will, um, your interview. Next, screen for compensatory behaviors. All right. Go a little bit deeper in regards to the behaviors and what are they actually addressing or what are they doing. I'll give you just a brief example of this. One time I was working with a patient, and I noticed that they were talking about their work trend, and I was noticing how incredibly productive that they were. I was like, wow, that's, very productive. And they're like, oh no, but it's like very difficult. And they said, I can only really work on something for 10 to 15 minutes. I'm like, you can only work on something for 10 to 15 minutes, but you're so productive. And she had said, I learned to cycle things every 10 to 15 minutes because I wouldn't be able to maintain focus. But they had developed this compensatory strategy. And then once, I'm not saying that in and of itself is like a definitive every time you see that. But that the cycling that frequently was a little bit unusual for me. And then we started to probe and we dug a little bit deeper. And then we did discover that this patient had a family history of ADHD in both parents, that they had dealt with symptoms of inattention early on, but their parents did not want her to be diagnosed because they felt as though that she would be unfairly judged as they were. So that is just a quick, if you will, clinical, if you will, scenario, but one that actually occurred. But again, this idea of looking at compensatory behaviors and asking yourself what's behind the compensatory behavior, particularly if it strikes you. So next, obviously you want to screen for commonly co-occurring disorders. I've pretty much, hopefully everybody's at this point realized that I've completely hammered home on this idea of the inattentive type of the presentation. And then obviously supplement the interview with appropriate, if you will, collateral information when appropriate. Okay, let's get into treatment considerations. First, probably the biggest thing that I want to say is that the medication recommendations do not differ by sex and only modestly differ by age. In other words, you should be treating females with the same medication that you would treat males for. Now, with that being said, with um, the context, though, in terms of life stage and different things, whether it is pregnancy, menstrual cycle, these things do need to be taken into account. But the recommendations in and of themselves, in terms of the use of a stimulant medication, um, do not change. All right. Okay, so ADHD is commonly treated with the psychostimulants methylphenidate and amphetamine. All right, just super duper quick primer on methylphenidate. It blocks norepinephrine and dopamine reuptake. Amphetamine does the same thing, except it actually gets put into the neuron, and it can be a bit more robust in regards to it because it blocks another receptor inside the neuron. So methylphenidate and amphetamine, they both increase norepinephrine and dopamine. Again, that noise and signal, but amphetamine actually not only does it block it from the outside, it goes into the neuron. So that's a quick primer on that. You can also use non-stimulant medications such as atomoxetine, clonidine, or bupropion. In my experience, non-stimulant medication can be helpful at the margins, but also with those with maybe a low to a moderate level of ADHD. Frequently, clinicians have frequently used bupropion. I've had limited success with atomoxetine, but these are good medications to have in your toolbox. Um, and all the above medications except bupropion are recommended by an expert level panel in regards to ADHD medications, pharmacological treatments. But the take home point for this is that the medication recommendations do not differ by sex. All right. So you should be considering the same treatments, stimulant treatments. I bring this up because women are frequently undertreated. Even though they get diagnosed as adults, probably less than 50% will actually be put on a stimulant medication. Now, there can be a variety of reasons for this, but the use of stimulant medications for formerly diagnosed ADHD is quite evidence-based. Now, obviously, everything starts with a discussion and people's choice, but we have to really be thinking about that. And part of that discussion, when we start to think about pharmacological treatments, we have to think about there are definitely potential benefits. It improves the core ADHD symptoms. We can reduce the rate of comorbid conditions, and we can reduce the rates of treatment-resistant depression. And we can also improve educational and occupational outcomes. Potential risk. There can obviously be many. I'm not going to detail all of them, but certainly a risk for development of substance use disorder, appetite suppression, exacerbation of comorbid symptoms, anxiety, and with ADHD medication, we typically, if possible, avoid or advise avoiding during the first trimester of pregnancy, as well as breastfeeding. But this is a much more detailed discussion, which I'm not going to get into here, but I'll touch on just briefly. But I do want to pause for a moment in terms of the exacerbation of comorbid symptoms, particularly anxiety. I mentioned before, um, in regards to the prevalence of any anxiety spectrum disorder in females. All right. It is not infrequent that you'll have as a clinician, you will actually treat someone who has either generalized anxiety disorder, social anxiety disorder, or even just major depressive disorder with an anxiety component, who also has comorbid ADHD. The challenge with that is that the treatment with the ADHD medications absolutely can increase the level of arousal and anxiety. All right. Like no doubt about that. However, you still do want that stimulant medication if possible because you want to fine tune that noise to signal ratio and improve that selective attention as well as that problem solving and sustained attention. Um, I can tell you from personal experience, finding the optimal zone with patients that suffer from significant anxiety and ADHD is it really starts to get into art. And that's really where the collaboration with your patient comes in and understanding the symptoms and what medications work, what don't work. This is where non-stimulant medications come into play. And I can tell you from my own personal experience that if you treat someone over the time frame of their life, let's say from 18 to 30, the different combinations that you're going to use at different points of time are going to be different. So I bring that up in regards to particularly that comorbid symptom of anxiety, because that can be a bit of a challenge and people are in a very difficult spot because while you benefit from the medication from focus, it's you're making one, you may get more focus, but you can make your anxiety completely worse, which really it quickly becomes diminishing returns. All right. So general principles. All right. Preferred treatment approach in ADHD. I can't emphasize this. Behavioral therapy plus medication. All right. Behavioral therapy plus medication. And by that, I'm going to refer to some evidence-based therapy. It's not some, but CBT is the therapy right now, currently of choice. But I think that many others could also be of benefit, whether it's interpersonal psychotherapy, whether it is brief psychotherapy, but some form of therapy plus the medication. Because as you saw before, like any mental health diagnosis, there can be many associated psychological sequelae or targets that need to be addressed, but particularly in someone who has been undiagnosed with ADHD and they're coming to terms with it. So behavioral therapy plus medication. All right, choice of medication without comorbidities. The expert panel thinks of amphetamine over methylphenidate or other non-stimulant medications. That's a starting point. That's a recommendation. I can tell you that with many of my patients, we've gone many different places with all of these medications, and they come in many different flavors, whether it's short acting, long acting, patches. So that in and of itself is its own lecture. All right. Now, the next thing is what would be the choice of medication in patients with co-occurring disorders. Substance use, if you have a substance use disorder, you got to treat the substance use disorder first. If unipolar depression, people would say consider the use of bupropion. All right. And then anxiety spectrum disorder, which I've had success with. I would say you need to address the anxiety disorder and starting with a selective serotonin reuptake inhibitor or an SNRI, and then you can start to add another stimulant medication. All right. Now, so these are again general principles. All right, skip that one. Management of ADHD in pregnancy. Now, with anything, it always starts with a discussion, but you have to weigh the risk of intrauterine exposure versus risk of deterioration or functioning. For mild symptoms, when you look at the evidence base, many would consider cessation of the stimulant medication for the first trimester. With one of my patients where this was the case, we did stop the medications for the first trimester, but also in regards to that, we didn't just stop the medications. We made a overall life plan in terms of how we addressed all the different stressors in her life. So it wasn't just decreasing the medication, it was doing things not only decreasing the medications, decreasing the stressors, but also adding in some other specific skill sets, if you will, or reinforcing them to work to help her cope through not having the medication. The next is moderate to major symptoms. You need to consider the risk or benefits of continuing treatment because some would argue in that particular case, with particularly major symptoms that cause significant dysfunction, that the benefit could outweigh the risk. Now, in terms of the risk of congenital malformation, it's not firmly established with methylphenidate or amphetamine. I'm quoting here, if you will, a study down here in terms of that meta-analysis in the rate of congenital anomalies in those exposed to methylphenidate or atomoxetine as compared with non-exposure to either medications was similar. This is again, I did not plan on this to be per se. I'm focusing most on the diagnosis of ADHD in females as opposed to the management of ADHD in pregnancy. I think all of these, whenever you're any psychotropic medication in pregnancy, but particularly but also stimulant medications, it starts with a discussion in really determining really the risk and benefit. What are the patient's goals? Where are they at with it? And then just helping people make an evidence-informed decision. So I don't think you reflexively say just stop all medications, but I think everyone has to know exactly what are the risks out there. So this is one study that I showed, but there were some studies that did actually show that there could have been an increased incidence in malformations, but the majority did not. So again, I will go back to this. It is not firmly established as of my research on this. Okay, now potential themes to target in psychotherapy, particularly as it relates to women. Um, this was this was taken from a study titled where they did a systematic review and they looked at different themes in women misdiagnosis, and they did a systematic review of all the studies of ADHD in women, and they identified some themes that frequently come up and that can be, if you will, targets of therapy that women dealt with, particularly with a diagnosis of ADHD as well as on lack of or not being diagnosed. The impact on the social and emotional well-being, difficult relationships, lack of control, and self-acceptance after diagnosis. All of these can be, if you will, in my humble opinion, targets of psychotherapy. And you can do them, you could attack any one that you wish, but probably the thing that in terms of the way in which I think about it is I actually usually start with the impact on social and emotional well-being, in terms of the disruption that it can be causing at their work, and their performance, addressing that, really getting at that idea of that you're dealing with a condition and also trying to look at the different strengths that you've already exhibited while dealing with that condition. Next, you start to look at and you don't have to go in the order in which I'm talking about it. You can start to look at the difficulty in relationships. The next one is lack of control. And then finally, the core of it is self-acceptance. I just did that artificially because when I work with patients, I actually have different topics that we address. But in reality, you're doing a lot of this at the same time. But this is just an idea, if you will, of different themes that females, particularly those who are dealing with a new diagnosis of ADHD or ongoing, face. This is in no way, shape, or form, if you will, just exclusive to females. I could put the same thing here for males, but I do think because the research was done on it, it can give people a useful starting point to start to think about it. Okay. And now, cognitive behavioral therapy, because this is one of the evidence-based approaches that they talk about in regards to working with females with ADHD. Again, it's simple and powerful. Again, you take a look at the event, you examine the automatic thoughts, you can target each one of these things. How do those automatic thoughts cause a certain level of emotional or arousal? What are the behaviors, maladaptive or adaptive? And then what are the results or consequences? The nice thing about CBT is that you can target every single one of these. Let me give you an example. Um, okay, so in here you can attack ADHD in four areas. Okay, in regards to belief, we can go to the level of belief in regards to ADHD. Frequently, when I work with those with ADHD, there can be self-doubt, low self-esteem, heavy levels of procrastination, and actually use of perfectionism. But it gets at that idea of either I'm not worth it or worthwhile. And then automatic thoughts. So one of the things to work with in terms of patients is this concern over mistakes and helping them proactively address it and not beat themselves up over it. The other thing in regards to ADHD and regardless of the medications, I'm just picking one target. Um, Procrastination and figuring out why it worked in the past and why it doesn't work anymore. And then I think that in terms of results and consequences, I think it's very useful to have mentorship so people can, or different folks, that they can get a realistic appraisal because it's not uncommon, particularly in my experience with females, for there to be a really bias towards a negative appraisal of superb work that was being done. All right, so I'm just giving you a very rough idea of it. But this is, you could do this. And then because this is a Resiliency and Wellbeing Center lecture, it would be foolish of me, and of course, people who know me know I love to do this, is to talk about different things that can be targeted in regards to resilience in terms of working with women, but particularly with ADHD, but anyone really. These are the top 10 coping mechanisms or resilience factors. I put this as a very uh, common part of my therapeutic regime. I highlighted some that I particularly like are radical acceptance, being optimistic and realistic, and role models. All of these are fair game, but I think that if you don't have this as part of something that you're actively trying to develop with any patient, I think you're missing out. And then finally, I'm going to conclude with the whole health wheel. All right. If we think about the female presentation of ADHD, predominantly in the inattentive type, but we think about it in the fact that there's frequently late diagnosis, there's missed opportunity. All right. There's missed opportunity in regards to addressing things early. There's missed opportunity in regards to preventing other comorbidities. All right. So what we want to do is we want to ask ourselves, we want to be curious about whenever we see symptoms of inattention or if you will, cognitive issues. In addition to that, once we are sensitive towards this and we start to either identify outright formal diagnoses, that we want to go beyond just the diagnosis step. We then want to actually have a collaborative conversation with the patient to understand their own life story and then to pick the appropriate medications or not, pharmacological or non-pharmacological, with the therapy. All right. The therapy should be targeted at, if you will, certain things that are common themes, but always in collaboration with the patient. But then the next thing that people miss is that they do not take a whole health approach. Every single one of these areas, whether it's support and belonging, the prevention and natural movement, the environment, the nutrition, the recharge, I can map all of this back to everything that I just said. So when you do all of this, because what we're supporting attention, we want our patients to be attentive and aware so that they can identify purpose. If we have attention and awareness, we want our patients to be aware so they can identify purpose. If you have that, that's going to blend all of it together. And that's going to be the thing that makes your treatment stick. And you're going to you're going to go from a disease paradigm to one of, you know what happens when I take the weights off, so to speak, of dealing with this condition and realize all the strengths that I have, and I can pursue my purpose with full attention and not miss an opportunity. So there you have it. I am done. Thank you for your time. If some of it made sense, great. A patient taught it to me. If not, then I was being an acute academic, which I don't like.
Well, wonderful. Thank you so much. We are a little short on time, but there are a couple questions if you have a moment. One of them is about trauma history and ADHD symptom development. I know that could be a big topic, but perhaps you have a to be continued comment.
Let me just see if I can. It's 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 too important and it should be a to be continued
Right.
topic.
Okay.
However, but this is what I would say. If I had to pick, actually, even before ADHD, definitely, in my experience, when you want to get significant and sustained gains with patients, you have to search for the trauma history or the ACE, period. Period. There's a period. So I would say that that is maybe Victoria and I can tag team that down the road, but it is too it is too important a topic. And also, Victoria, the unfortunately the topic is understudied. ADHD in women is understudied, but yes. And let me see. Can we connect with a proprietor at GW to speak with? Danya, yes. I will see I will connect you with some folks in regards to I'll coordinate that with Lee to see who can do this. And also the other thing is one of the reasons I was being careful in regards to my discussion of the use of psychotropic medications in women is because at this point in time, my own personal practice, and she was our original women's well-being champion, Lisa Catapano, I would go knock on the door and I'd say, Lisa, talk to me, and I would formally have my patients go and consult with Dr. Catapano and then come back. The same way if I wanted to do something in regards to, I'm just saying something in regards to mindfulness or whole health hour or nutrition, I'd say, I need you to consult with Dr. Frame. And then after you do that consult, you come back. So I think it's literally to that level in terms of you benefit from that level of expertise because it gets that complicated. So I probably myself would no longer try to manage it alone unless I'm frequently doing it. And then yeah, well, Kristen, I'm absolutely great that it really is of support. But again, I can't emphasize this enough. If you if you broaden it to, I want to support my patient in optimizing their strengths. I said that on purpose. Then you're not going to miss it because you're going to be looking at everything. Okay, that's a strength. That's a strength. And I meant what I said. Maybe I'll close with this story or whatnot. The patient, that one particular patient that I was talking about, that I was working with, that I had the pleasure of working with for years, going with the self-doubt, the medication trials, X, Y, or Z, this, that, or the other, um, questioning herself, all of these things, the many different permutations. I can't, because I don't want to divulge who the person is or whatnot. That person is now a leader, a senior leader in charge of X, Y, or Z. So that's a testament to her. But I think that if some of the things that I say made sense, I wish I could say her name. I want to give her the credit because it was a very unusual experience because I worked with that person ever since 2007. So I've literally seen that experience. Um, Anything else, y'all? Happy to good. Okay. Oh,
I
hey,
think
John.
we're good.
Oh,
I think we
okay.
will take you up on that offer for you and Victoria to do a follow-up on this because I know trauma is one of those big
Well,
topics and adding it into the
trauma
ADHD.
is one of those big topics, but also, um, gosh, we could just have a lot of fun with this now. But I got to get back to work. But no, this is because Victoria and I are both aware of this as well as Lee. How I have also sat on multiple professionalism committees. I've sat on
Mm.
multiple committees in which students are in risk of academic dismissal. All right. And I'm sure Victoria could share with you I get so upset, literally, when I see students, as well as residents, as well as a lot who have the wrong diagnosis. It's quite clear and apparent to me that this not only do they have the wrong diagnosis, they do not have a whole health approach. I'm going to keep on saying that. They don't have a whole health approach. And I've seen the results when people do have that, whew, not everybody, but flourishing. But frequently, when you see, and yeah, I want to leave with this when you see someone not performing or X, Y, or Z, I want you to ask yourself, is it truly an issue of motivation? Are you really challenging yourself? Is this truly an issue of motivation? Or is this person really working their butt off and there's something else that's blocking them or not allowing them to achieve their potential? If you're not training yourself to ask that question in your professional settings, whether you're treating a patient or not, I think you're missing the boat. I've seen it too many times in at our professionalism meetings, and then that gets into organizational well-being and how we structure things. But in any event, all right, I'm gonna stop now because I could just kind of keep on talking. Okay.
Well, thank you so much. We're so glad to have you. And thank you all for joining us and hanging in for the extra time. It was that good of a conversation. This recording will be available and you will be able to send it to your loved ones if you think that will be helpful as well.
Yes, please do.
Bye, everyone.
I know.